Thank you guys for joining us today for the Ultrasound Grand Rounds. I'm excited to see this thing growing and see just the fruits of our labor just kind of spilling out here and just kind of bringing education to everybody. And so to have multiple people on from multiple different institutions is really cool today. But today, I'm excited to bring our frequent guest speaker, Dan Mirsch, a friend and colleague from over in New York, who's going to be talking to us about ultrasound and using that to help us gain our disposition in our patients in the ED. So without me talking much longer, I'm going to turn over to Dan, let him give us this presentation. Like I said, at the end, we'll do some Q&A and some discussion, and this will be a fun time. So Dan, take it away.
Thank you very much. I appreciate the invitation. Also, I'd like to just make sure that anyone who gets an invitation from Matt to to do one of these presentations, just say yes. Don't think about it. Just say yes, come up with something and do it, because it's really valuable for a lot of reasons. And I highly encourage everyone to do that. So this lecture came out of a couple of experiences. Obviously, many of us have been dealing with very full waiting rooms over the past couple of months and years since the COVID rebound. And I find myself using the ultrasound more and more to make some very quick clinical decisions while I'm in the triage room. So that's where a lot of this came from. Forgot to do the introduction for myself. My name is Dan Mirsch. I'm one of the assistant professors at University of Buffalo, which is a part of SUNY. I am the student course director, and I also do some dabbling with international ultrasound with Dr. Romeo Wahome in Kenya, with some projects, South Sudan with Dr. Fideli Dan. And then I also help with research in our division. I have a couple of hats, but the point is, this particular topic spoke to me over the past couple of months. All right, so let's say you're in the triage area. For me, it's basically a room the size of a bathroom with a nurse who does the triage and gets the patient registered, while a provider sits behind that person in a chair. The patient sits in a chair next to the nurse, and the two of us have computers to just kind of get everything started, put in orders, and then you have about 3 minutes to get this done. And then the next patient comes into the room, because obviously there's 10, 15 patients waiting to get triaged, and the longer they wait, the more dangerous the situation is. So I'm gonna tell you a couple of stories. I had a 23-year-old guy who had a history of cerebral palsy and a multitude of abdominal surgeries previously. Came in with abdominal pain, nausea, and vomiting. And my major concern was small bowel obstruction. So I just pulled out the ultrasound, put his info in, and then just put the probe on, and it was very clear, bowel obstruction. So I called surgery. I said, hey, we just had a bowel obstruction arrive here. The CAT scan is currently pending. Everything's ordered. This is their name. Please come and evaluate them prior to CAT scan. We have an agreement with our surgery team that we can request that they come and evaluate and do a physical exam on a patient prior to CAT scan, which was the result of many M&Ms. So that is a part of this discussion, as well as looking at how your relationships with colleagues can be affected here too. I had a 50-something-year-old guy come in with leg swelling one time. I was able to take him to another part of our triage area that has the bed, laid him down, did a quick point of care DVT ultrasound, and found a popliteal clot on that guy. So I told him, like, all right, you have a DVT. We need to see how extensive this is. And he had also complained of some shortness of breath. So he needed that whole PE rule out, which I put in for the computer, and then logged him as an ESI 2 instead of an ESI 3 or 4, which he had originally been made. And then finally, we do not have ophthalmology at our institution. And I had he's in his 70s or 80s, come in with unilateral vision loss, put the ultrasound probe on his eye, immediately saw a retinal detachment that said, you need to go to the ophtho referral center, which is our trauma center. And so he immediately just packed up his stuff and said, I'd rather go by private vehicle. His wife was there to drive him, and we just did the paperwork, and he left immediately. So these three cases illustrate how, depending on what your relationships are with your consultants, what the patient is presenting with, and what resources you have, you can very quickly come to a disposition and get the patient the best care possible as quickly as possible. The objective of this lecture is to know which scans can decrease length of stay in the emergency department most effectively, how we're going to make systemic change to gain those benefits, and then know which scans can be done in patients who are in a chair. Sometimes it's just logistics. So door to disposition times matter a lot, especially as you become an attending or a fellow. You will see these metrics mentioned at your quarterly, yearly, or biannual review, and you get graded on those metrics. So the flow of the emergency department is heavily dependent on this. The costs associated with your department, if your patients are waiting around too long, you can't see as many patients, and then you can't make as much money, and your boss doesn't like you. Patient satisfaction scores are heavily dependent on wait time. That's kind of out of our control, but the less they wait, the better you'll do. And if you have a provider in triage, often patient satisfaction is much higher. Also, your left without being seen numbers are much lower. So that's just kind of like another side note. Your patients per hour will be much higher if you are able to get people through the process sooner. Your RVUs will be higher because you're seeing more patients, and your paycheck or bonus will be higher if you have a metric that's part of your bonus structure or incentive structure. So these are all elements that I think are very important for attendings and fellows to understand, because it also helps to understand how much you actually have to work and how much you could possibly be home with your family or doing things that actually matter to you instead of being in the emergency department. Our most effective and highest yield scan is the first one I mentioned. So the first one I mentioned, let me just see what this chat is about. Data also is the teachers who get POCUS are happier with their care. That's very true. Very true. That was Vicki Noble did that study a bunch of years ago, and there's been a bunch of other studies since then that also show that patient satisfaction when you do ultrasound on them is much higher. Plus, you're spending more time with them, which also increases patient satisfaction. Also, people just like to see their insides. So the small bowel obstruction in this study showed that there was a significant change of around 211 minutes, so 3.5 hours difference between point of care ultrasound and CT scan. So one of the reasons is that even though the Radiology Association says that small bowel obstruction does not require oral contrast, most surgeons still ask for it. One of the reasons they state, and I don't know if I believe this, but they state, is that they want to trend where the contrast goes after they get an NG tube. And so if they open up, sometimes the contrast will release down further into the bowel structure down to the rectum, at which point then they know via X-ray the patient likely had release of the bowel obstruction spontaneously, rather than needing to go to the OR. So there is that side of the equation. So doing oral contrast at our institution has been mandated, which sucks, but here we are. So if you can save 3.5 hours saying like, hey, I put the ultrasound probe on this patient and they very likely have a bowel obstruction, please come and see the patient. The surgeons often will try and expedite the CT scan because their whole workflow is kind of dependent on that. They may opt to not get the oral contrast, or they'll admit to their service pending the CT, which would be the optimal outcome, because then they get out of your department and get admitted to the surgical service and get their NG tube. Basically, they get treated as if they have a small bowel obstruction prior to the CAT scan even being read. So that would be the optimal outcome. How we get there is a discussion we'll get into in a little bit. First trimester pregnancy is another one that has a high yield. You can get about a little over an hour to an hour and a half benefit here, where if you do the ultrasound yourself, whether it be by like the curvilinear probe phased array, or even Matt did a nice study on using the linear probe in some cases where you can't see the possibility of a pregnancy. If you can see a yolk sac in the uterus, or you can see a fetal pole, and you have the patient's not an in vitro fertilization patient, you can very clearly say that this patient has an intrauterine pregnancy. It is not an ectopic, and they, based on the situation, can go home or get whatever appropriate disposition at that time. So there's huge savings with first trimester pregnancy. Another one is renal ultrasound. So this will be coming up when Sandy and I are at the Journal Club starting at 2 p.m. So if you guys are free at 2, please come to that. We can compare CT versus ultrasound for renal colic and found that there's an average savings of about an hour. And so again, you come and see the patient, you bring the ultrasound with you, you take a look, it's like, oh, hey, there's moderate hydro here. that fits your description of a kidney stone, we recommend NSAIDs, Flomax, filter your urine, and then give it a week or two to pass. And if it doesn't, you're going to follow up with urology, and they might order a CAT scan. So may not be appropriate for first-time stones, but people who have had stones before and say, like, this feels like my kidney stone, you get the ultrasound, you're done. That can be a great savings of about an hour for disposition. One of my personal passions is DVT. And so in this study, we found that there was an average savings of over 3 hours when the emergency medicine physician did the study instead of sending the patient to radiology. We find this very often at my institutions, whether it be the vascular center, the VA, I think at ECMC as well. Sarah will be able to speak more on that, but it takes quite a while for radiology to do these studies. Whereas if you perform it, you get that huge time benefit. So this is another area that can be very, very helpful for you to just bring the ultrasound with you. Patients said, like, hey, my left leg blew up over the past 4 days. I don't know what's going on. I'm concerned I have a clot. Just go in there with the machine and find out. Don't worry about, all those other factors. Another one that I've diagnosed in the waiting room a couple of times is people who come in with abdominal pain or epigastric pain or right upper quadrant pain, and you very quickly can just put the probe on, look at their gallbladder, like, yep, walls thickened, you got perichosis fluid, you got a big stone in there. I think you have a hot chole. And then I just call surgery right then and there. I'm like, hey, I got a hot chole in the waiting room for you. Just let me know when you're down here. I'll pull them into one of our triage rooms and you can do your exam. And they're like, oh, fine. Often this happens at like 11 at night when the ultrasound has already gone home. And so they don't have a better option other than CAT scan. The CAT scan's ordered, but I already know what's going on. And I did a better test than CAT scan with the point of care ultrasound. And again, this time savings here can be about 2 hours. Note that the surgical disease processes tend to have much higher savings than some of the other processes. So that conversation with surgery, we'll talk about in a minute. Aortic dissection, this one, the amount of cases involved, this was a retrospective study. I believe it was at a Temple where they found that there was an approximate savings of around an hour, where if you had concerns for aortic dissection and you did a point of care ultrasound of the heart and the suprasternal notch, that would be a good way to try and find the flap inside the aorta. And if you found the flap, your specificity was very high. So this is, again, a lot of these ultrasounds are about rule in, not necessarily rule out. So if you're in the waiting room, you're doing these studies, or your first exam of the patient, you do the study, you find the answer, that's where all the time savings usually comes from. If you don't see the answer, you have to let them go through the entire process of either CAT scan or radiology ultrasound. And that's, kind of, the normal process that we're typical of expecting. But the specificity of ultrasound is where a lot of that time savings comes from. So the aortic dissection, you would look at the aortic outflow tract and a peristernal long axis of the heart. You would do a suprasternal notch. You can do from like a peristernal short axis, but rotate it a little bit. You can get a long axis of the thoracic aorta, and then finally in the abdominal aorta, looking at it in longitudinal to see if there's a flap presence. This is a suprasternal notch view, and you can see the flap right here. Again, the time savings here is about, whoa, I think I got kicked off. Let's see if we can get this back. Is everyone still with me?
Yep.
Very good. All right. All right, so if we look at our time saved, we find that the small bowel obstruction was one of the best ones. DVT was another really good one. Biliary, first trimester pregnancy. There are others that are really helpful, such as like congestive heart failure, looking for B lines, reduced ejection fraction, and plethoric IVC. And then the other ones that we talked about. And so your time savings with these different diagnoses can be very high. And given the frequency with which we see all of these things, you can really decrease your length of stay and your time to disposition. Chats. So which one? It looks like Elon Musk. All right. So how are you going to get there? That's one of the questions. So combined surgery rounds is one way to have these discussions with general surgery about things such as bowel obstruction, biliary ultrasound, vascular surgery with the aortic dissection, and to like get those conversations rolling. Another way is that if you perform a retrospective study at your institution with your ultrasounds and say like, hey, every time we've said that there's been a bowel obstruction, there was. You need to pay attention to when we say that the ultrasound says there's a bowel obstruction. Now, if your data does not support that, then we have to work on our own game and make sure that our ultrasounds are accurate. Another thing to do is to have maybe private discussions with key surgical attendings who are the makers and shakers of the surgical division, who help to make the real decisions and drive policy. And so if you can bring that retrospective data to them saying like, hey, I have data that says do this thing, you should do it, and let them hopefully have a conversation with you and not be obstinate. All right. So this next portion is going to be how to scan people in chairs. Any questions so far on the previous section? All right, we'll save the questions for the end. That's fair. So chair scans. You have a couple of different limiting factors when doing ultrasound in a chair. You obviously can try and lift up their shirt, pull down the pant area. Obviously don't want to get too private because there's multiple individuals in here and often this is not the most private of areas. So we also have to think about sensitivity and specificity. As we go into the chair, all of our sensitivity is going to go down because we're just not going to be able to get the optimal scan. And so you really want to focus on the specificity, which we've already talked about. So things like small bowel obstruction, renal dissection, DVT, pregnancy, gallbladder. If you have concerns for things that you are highly sensitive about, again, you can try to look for these things. I can't imagine doing an aorta is going to be very easy in the abdominal area. With this, you can look for abscesses in IV drug abusers, CHF and short of breath patients, pneumothorax. All of these things I think are valuable. You just want to make sure that you're being careful because you know in a chair, your scan is not perfect and you need to have that understanding at the very beginning right before you do the scan itself. So this patient probably not going to be optimal to scan in a chair because it's going to take a while to get anywhere with this patient. So just move on. So let's say that we have a 35-year-old with a history of asthma coming in with cough and left-sided chest pain. They said that they had sudden onset left-sided chest pain after they had a coughing fit from their asthma and they've been using albuterol, blah, blah, blah. And then you see that there's no lung sliding on that side. That person obviously would go for chest x-ray, not that it's more sensitive or specific, but it's what surgery and thoracic understands much more quickly. And you would probably room them as an ESI 2 or even 1 with concern that they have pneumothorax. COVID was a big one. We actually had a COVID triage protocol where we would try and ultrasound a lot of our patients who came in with COVID symptoms because we saw in, if anyone's been on the ASAP Journal Club last year, the lung episode, we had the author of the study who showed that in a high prevalence, like in the middle of a COVID wave, in a high prevalence situation, the ultrasound can be more sensitive than PCR testing with a combination of symptoms and the ultrasound findings. So if you see those B lines and kind of shredded lung tissue without a pleural effusion, that can be a high predictor of COVID. For CHF, like we talked about, if you have a big plethoric IVC and you have these B lines and they have a history of CHF, that's a quick and easy disposition. Whereas if you have a very thin IVC, much less likely to be CHF, probably needs more of a workup, and that person can start their workup from the waiting room if they're stable. The abdomen, again, we talked about small bowel obstruction, gallbladders. There have been a couple of times where I found free fluid in patients who were quite sick and immediately got roomed, found to have perforation. And then we talked about our renal colic patients who often end up sitting in the waiting room for quite some time because often they don't really need an IV or IV medications. one where you diagnose the retention on ultrasound, you pull them into a private room, you put in the Foley catheter, and you discharge them, and their total length of stay is maybe 20 minutes. Whereas if they stay out in the waiting room, that bladder is just causing them more and more pain, and it can be very difficult. Again, we talked about things like ectopic pregnancy for someone who has concerns of, I think I'm pregnant, I haven't had a period in a little while, but I'm having all this pelvic pain. You find the ectopic and you immediately move on to putting them in a room, consulting OBGYN, and if necessary, getting a formal radiology ultrasound if they're available. If they're not available, this is it. And you need to show this to OBGYN so that they can make their clinical decisions. Appendicitis, very similar, trying to look at that right lower quadrant. Again, this is often under the belt line, and so it's often less able to be done in a chair, but can be attempted. All right, we look for abscesses, especially in IV drug abusers or foreign bodies, to see if they have like a needle stuck in there, which may require more care than the typical abscess, and might, instead of going to fast track, go to the main emergency department. Looking for ischemic limbs for like a pulse check of either a foot, or in a couple of cases I've had, a patient came in as a stroke alert, said they had a lot of arm pain in addition to their weakness. We looked at their radial and ulnar arteries, found that there was no pulse, tracked it up to the brachial artery, and there was a clot in there. Doing 2-region DVT, trying to go like right below the belt line to get the iliofemoral, and then going to the popliteal can be an option. Just realize that that's not as sensitive or specific than doing the full protocol. Shoulder dislocation, you can diagnose that in the triage area, see that the shoulder is out. You can try and attempt, if this is someone who's dislocated multiple times in the past, you can attempt to put it in with like a Cunningham maneuver while they're in that seated position, and then watch in real time to see if it's successful. And then, like I talked about, the ocular scan, especially if your institution does not have ophthalmology on call or on site, to immediately send this patient to the appropriate institution can be very helpful. So here we see that the line of the retinal detachment is anchored at the area of the optic nerve, whereas the vitreous detachment floats over the optic nerve, optic disc. Again, vitreous hemorrhage, a lens dislocation, and then significant eye trauma such that this eye needs to probably be removed with globe rupture. So overall, POCUS can decrease your length of stay, it can increase your patients per hour, increases your RVUs, assuming you're billing for your ultrasounds, and you can do chair scans to rule in disease processes to save you a lot of time and get patients the best care possible.